Well, good morning. This is Dr. David Spiro. I'm the Chief Medical Officer and co-founder of ReelDx. It's awesome to hang out with you all this morning. I'm incredibly honored to be here today with Dr. Chris Moore, Professor of Emergency Medicine at Yale University, and presenting ReelDx Classroom. We are co-sponsored by POCN, Smarty Pants, and Heal, amazing partners in this journey as we continue to deliver vivid, incredible, real patient content that will drive case-based learning and education for the future generation of healthcare folks. And we're excited to be here today to talk to you all and present this exciting case authored by Dr. Chris Moore. Welcome, Chris.
Hey, David, how are you?
Good. Really excited to have you here and chat about this amazing case. Before we get going, would like to just present a few house rules. Please, we want this to be interactive. So please put in a quick hello on the Q&A. Let us know where you're Zooming from today on this webinar and where you're at from a education standpoint. Are you a student? Are you an attending? We'd love to know that as we get into this case, and that will be helpful for us. So we want this to be interactive. Don't be shy. That will make it super exciting. Otherwise, you'll hear two middle-aged men banter back and forth about a case in silence. And we want to engage with you all. That's part of the learning. So please use the Q&A chat box. This case will be somewhere between 30 minutes and an hour. I don't know how long we'll get to, but we'll see how we proceed and go along. Today, the learning objectives are to discuss the options for managing the patient with acute onset of atrial fib with rapid ventricular response and when cardioversion may be indicated. Define different ways to achieve cardioversion, and identify key steps to procedural sedation, including setup, choice, and dosing of agents and intraprocedural monitoring. This case is very rich. It's multiple parts. Hoping we get through everything. We'll see. And I'm going to get back to the ReelDx platform. Chris, any other learning objectives you wanted to share or pre-case a priori thoughts? Oops, looks like we lost Chris for a second. I'm going to pull up the case.
Oh. Can you all hear me? I think might have been a minor snafu there. Can you hear me?
I can hear you. Maybe better if you just turned off your video if that happens again, or your internet is unstable. That may be helpful. But can you see the case, Chris? And are we ready to go?
I can. You mentioned it, but it would be really helpful for me. I thought there were like 15 participants. I do see one that put into the Q&A, but it would be great if other people could put in where they are learning wise and where they are physically, so I have an idea of the audience. So would just really encourage people to do that, and then we can get started. Thanks.
Well, while people are putting in who they are and where they're from and what level they're at, why don't we get going with the case? And Chris, I'll play it, and if you'd like me to stop it, let me know along the way. Does that sound okay?
Sounds good.
Hold on. Yeah. My heart was beating.
Let me start it from the beginning.
All right. Good morning. I'm Dr. Moore. We're here at Yale New Haven Hospital. How are you doing today?
Good.
You mind just telling us again what the reason was you came into the hospital?
Hold on. Yeah. My heart was beating. Yeah.
Your heart was beating fast,
Fast.
is that right? And it's up a little bit in the 120s right now. So you felt your heart kind of palpitating?
Yes.
Did you have any chest pain?
No,
Okay, and you had this before?
once before, a long time ago,
Okay, you have a history of atrial fibrillation, is that right? But you've been out of it for a while?
a long time ago.
Okay, and what time did this start?
Must have started yesterday.
What's that?
Must have started, when do you mean,
The,
today?
the palpitations, when did you feel them?
Yesterday.
Yesterday. Okay, so you've been here for a little while.
Yeah.
All right, and did you feel weak, lightheaded, or dizzy?
No, not really.
Any fevers, anything?
No,
Okay, so we're gonna go ahead with this procedure. Do you have any questions for us?
no.
Okay, I'm just checking your pulse real quick. A little irregular and fast, down to the 100s now. Okay, give us a second.
So Chris, real quickly, patient's vital signs 98.6, heart rate 123, respiratory rate 16, pulse ox 98%, blood pressure 137 over 56. Any sense of like when you walked into the room, any of those vital signs get you excited as a physician taking care of her? Or concerned?
Hopefully I'm unmuted here. I guess first of all, one of the things I really like about this platform is that, there's vital signs, but a picture and a video is worth 1,000 words. So just talking to this woman, even though her vitals are abnormal, she looks pretty comfortable, which is reassuring. The main thing that jumps out is the heart rate. It's in the vital signs, and also we looked at it on the monitor as part of that interview, and I did a quick pulse check. And so, in this case, I think it was pretty obvious and was mentioned in the history. She had a history of atrial fibrillation, but do you want to pause and just take a look at the EKG?
Yes. Let me.
If you scroll down to the bottom, I know it's one of the additional media tabs or whatever.
Here we go.
So I guess, the first thing when you see somebody like this is that you want to, assess, why their vital signs are abnormal. That vital signs are vital for a reason. And certainly with a tachycardia, an EKG is a pretty good place to start. So we see two EKGs here. Hopefully everyone can see it okay. The one is on the top is the initial EKG. We'll talk about the other one. So, and I'd love to see people being interactive on this. I don't know, does anybody know the physical exam finding that's kind of pathognomic for atrial fib, how you document that in the chart, or how you would do it if you were doing a physical exam? So you put your hand on the finger of the pulse, and classically it's described as irregularly irregular. So meaning if you look at the QRS complexes, which are the spikes, and lead 2, which is at the bottom here, is going along, and each QRS or spike is a conducted beat. And if you put your hand on the wrist, you'll feel each one of those. But you'll see that the distance between those is kind of, there's no regularity to it. It's somewhat fast, but there's varying distances, and that's what we mean by irregularly irregular. And that's kind of the classic physical exam finding, whether you're listening to the heart or taking the pulse, that you have an irregularly irregular pulse. So then the other thing is, when you see a fast heart rate, you want to look for the rhythm. Rhythm, the normal sinus rhythm would be a P wave preceding every QRS. And you could have sinus tachycardia, where you have a fast heart rate, but each QRS has a P wave in front of it. So we do not see P waves here. We see a very just kind of an irregular baseline. It's just kind of going up and down a very little bit, but no regular P waves. So this is pretty classic for atrial fibrillation with rapid ventricular response, meaning that the pulse and the heart has responded fairly rapidly to what's going on. So I don't know if we're having any interaction here, but if people are willing to put in the the Q&A, what would your first goals in terms of addressing this patient? What do you want to try to help achieve in somebody? Let's say, especially if she had more chest pain or shortness of breath. Does anybody have any thoughts on what you want to be doing therapeutically?
I guess the other issue, one of the attendees said no P waves, which is a good comment. There are some students here and some faculty members from that are attending. Chris, how do you actually? There are two questions I had. How do you discern the difference between a-flutter and a-fib? Because a-flutter can be irregularly irregular too. So how would you discern the difference between those two? And then also, if she were having signs of ischemia, how might you, along with a-fib, how would you actually discern that on the EKG?
Yeah, sure. So, I mean, atrial flutter, the classic finding on that is the sawtooth waves. You'll see a rate that typically can be as high as 450, which is the fluttering of the atria. So you see a sawtooth. Actually, a lot of times, if there's specific conduction delays like 2 to 1 or 3 to 1, you actually will see atrial flutter being more regular than a-fib. But the treatment is mostly the same. It can be a little bit different in the cardioversion, but the idea is that if you have someone with chest pain or shortness of breath, you may see changes in the ST segments, ST elevation or depression. Some of that can just be rate related, so it can be a little difficult to tell. But I see at least one comment in here: reduce the heart rate, which is actually the correct answer as far as the immediate management of somebody with atrial fibrillation and rapid ventricular response. Does anybody want to take a shot at what agents you might use in the emergency department to slow the heart rate, to control the rate? There's really two broad classes, and if people want to put specific meds in, I'd love to see that, so I can see if people know how to treat this in terms of rate control. So please feel free to put in the Q&A like the type of medication, the actual name of it, the dose that you would use. There's a couple different options here. So,
was her?
Right, I guess
did you feel her mental status was appropriate?
Yeah, I thought it was pretty good. I mean, I don't know if you had a different take on it, but she was quite interactive, and I thought was able to give a pretty good history of what was going on. Did you have a different thought on that?
I don't see adults. I'm a PZR doc, so I mean, I'm not seriously used to hanging out with older adults. So she seemed slightly slowish in terms of her sluggish in terms of her response, but it's hard to know what her baseline is. So, and I didn't know if she had any comorbid conditions as well. So.
Yeah, I mean, I don't know. She's a little bit older and she's in the hospital, and I think that can kind of, just make people a little bit, less bright than they might otherwise be. But I didn't feel that she looked, terribly ill. So looking at the chat here, I do see a couple answers. Samantha Thomason says BB or CCB, and hopefully you guys know what those acronyms are: beta blocker or calcium channel blocker. Those are the two options. A beta blocker, typically we would use metoprolol. And often if I want quick rate control, I'll give an IV dose of 5 milligrams and may follow that several times to try to get control. You can also give metoprolol by mouth. I might often give like 50 milligrams with the IV dose. And actually, that's a pretty good idea, even if we're going to talk about cardioversion, but just to try to make sure that they don't go back into atrial fibrillation, it's good to have an agent on board. The other one that is often used, calcium channel blocker, the most common one that we use is diltiazem or cardizem. And I do find that the calcium channel blockers, particularly diltiazem, is faster acting than the beta blocker. So for rate control, I actually tend to prefer that one. And I would typically give a dose of 10 milligrams of IV cardizem or diltiazem. The thing about that is it's very short acting. So you do really want to give that with something oral as well, so that once it starts to wear off, the medication will still take effect. So those are the two that I would consider right away. And there's not a lot of downside as long as the patient has a decent blood pressure and the heart rate's up. Sometimes you want to look at what medications they're on to try to avoid mixing the two. So if they're already on a beta blocker, low pressure or something else, you may want to stick with giving beta blocker. But it's certainly not unreasonable to, if you try one and it's not working, to switch to another one. So that's, I guess the first point is, how do you approach these in terms of rate control? And those would be my my tips on that. I don't know if you have any other questions, comments.
Looks like many,
So
looks like we've got some smart students and attendees. They're answering pretty accurately here. This is awesome. Thank you guys for participating. It's great.
okay. So rate control is important, especially if somebody has signs or symptoms of ischemia. Then the big risk from atrial fibrillation that we worry about, particularly if we do put them back into normal rhythm, is a stroke or CVA. CVA being cerebrovascular accident, where you throw a clot from the left side of the circulation up into the brain. And the reason that we put people on anticoagulation that are in atrial fibrillation is to reduce that risk of stroke. So in this particular patient, it's important to look at her history and the medications. So she's already on metoprolol. And that, again, gives us a clue as to, we may want to start with that in terms of rate control. And then Eliquis, which is one of the DOACs or NOACs, so the direct oral anticoagulants. And she's already been on that, which is good, because that way we can talk about other options to potentially, rate control her without worrying about stroke in most cases. So I guess I'll just take you through the case a little bit. I mean, in this particular case, we certainly could simply rate control her, and I would generally try to talk to her cardiologist. She probably has one because she's on these medications already, and see what they wanted to do. And I think that's actually how this case went down. And they said, if you guys feel comfortable performing a cardioversion, she's usually been in sinus rhythm, and we'd like to get her back into that. And that's what we talked to her about. And so we can go from there. But it would not be unreasonable to control the rate in somebody like this and talk to the cardiologist. And some people, they just leave in atrial fibrillation on anticoagulation indefinitely. And that, may be the case, particularly if they continue to go back into a-fib after cardioversion. So that's, where we were, but we did decide to go ahead with cardioversion. And I don't know if we want to move into just talking about that and different options.
Yeah, I'm curious about what factors in this case made you decide to move ahead with cardioversion.
Basically, it was, I think this is off camera, but there was some shared decision making that went on before. I mean, there are people who have been through this and they know what it is, and there are other people who haven't. You want to talk to the cardiologist and see if they think that it's reasonable to do it and that they would stay out of a-fib if you cardiovert somebody. I've definitely had situations where you cardiovert somebody and they pretty much go right back into it. And so to go through a whole procedure and to, shock somebody is not necessarily, the best thing if they're going to go right back into it. So I think it's important to, involve the cardiologist if you can, and also involve the patient and say, do you want to go through this? And, always, make them aware that it's still possible they could go back into a-fib, and, it may not be long-term successful.
I have found in emergency medicine that employing the technique of shared decision-making can be a very empowering act. And it's an important part of medicine, especially when you don't know patients who are able to make decisions, giving them choices, laying out all the options, letting them know what you would recommend, but informing them as best as possible. And that kind of bidirectional communication, I find is it's a very key part of practicing outstanding emergency medicine holistically.
Yeah, I couldn't agree more. I think it's important to choose when you're doing shared decision making, and that typically is in a situation where there is more than one possible way to approach an issue. And this is a perfect example of that. Again, we can do a cardioversion, and that's what we're going to talk about. But if somebody said, I don't want to go through procedural sedation and somebody shocking me, then that is also a reasonable choice. So there, certain situations in medicine where there's a reasonable person could make two different decisions. And I think that's the ideal situation, to involve them in that decision as much as they're able to and willing to.
One of the attendees asked, when would you start to consider amiodarone?
I mean, amiodarone, I use that more for ventricular arrhythmias. You certainly could use it for atrial. You know, it does have a side effect profile, so most people don't use amiodarone to control atrial fibrillation. I would typically do that in conjunction with a cardiologist if they felt that was the best route to go. But that wouldn't probably be my first line in somebody like this.
Fantastic. Do you want to take us through a little bit of the next stage of this? The patient had shared decision-making and decided to move ahead with procedural sedation and cardioversion. Should we play the video? Do you want to set us up for this?
Yeah, I guess the only other thing I would say is that, you know, there are different options when you're looking at, once you make the decision to go through with cardioversion. There are some chemical ways that you can approach it. You know, there's Corvert, there's also flecainide. And again, that's probably done at best in consultation with a cardiologist. They may know what the patient responds to well, but certainly, you know, the gold standard, and especially if somebody is unstable and you can't get them stable with rate control medications, you know, cardioversion is the way to go. And it's certainly a very effective way to get them out of atrial fibrillation. So that's what we're going to talk about next. We did, you know, discuss this with the cardiologist and the patient and decided to go ahead with electrical cardioversion. And in order to do that, you want to give somebody medications to, you know, make them procedurally sedate and so that they don't feel the shock and they don't remember the shock, because it can be quite uncomfortable. So that's where we are. We'd already made the decision to go ahead with electrical cardioversion, and then we want to go through the steps in preparing to do a procedure like this.
One question was, did you go ahead with electrical cardioversion because she was already on a beta blocker and anticoagulated and still hemodynamically unstable?
That's, well, I don't think it was hemodynamically unstable, I would say. I mean, she was tachycardic, you're right. We probably could have controlled her rate more. We didn't give a lot of medications before this. In other words, we could have gotten her heart rate down into the 80s, but she still would have been an a-fib. The reason we decided to go ahead with cardioversion was because this patient had previously been in sinus rhythm. And you know, people, ideally, you'd rather go through life in sinus rhythm and not a-fib. And again, sometimes it can be really hard to keep people out of a-fib, but if you can get them out of a-fib and they may stay there for a long time, it's worth doing the cardioversion, because rate control, well, some people will convert on rate control. A lot of times they don't. It's just, you're just simply controlling the rate and not the rhythm. So we made the decision to actually try to get her back into sinus rhythm, and that's why we went with the cardioversion.
Before we go into the pre-procedural debriefing, I wanted to ask, we're dispositionists on some level. Prior to engaging with the shared decision-making, did you know she was either coming into the hospital? Was, if you actually converted her out of a-fib, would that have been helpful for you to make that disposition decision, or was she coming into the hospital at this point no matter what? And if she was coming in, what would be the reasoning behind that?
Yeah, certainly. So, I mean, if you can get somebody back into sinus rhythm and that's how they were and they're feeling better, you know, there's no reason why you can't discharge them. And that certainly is a nice thing to do. We're certainly seeing a lot of overcrowding recently in our emergency department. The fewer people that we can admit, the better. You know, we also could potentially rate control her and discharge her. That's a little bit riskier just because maybe you get rate control initially, but then it drifts back up. And particularly if they're having symptoms like chest pain or shortness of breath, you may not want to discharge them. I typically would check at least 2 troponins and monitor them for a period of several hours, kind of regardless. But that, you know, doesn't mean you have to admit them. And I think that's the way we went in this case. We'll get to it, but.
Great. Should I go ahead and play the pre-procedural debriefing?
Yeah.
Okay, go
All
ahead.
right, so we're gonna go ahead and just do a quick timeout. This is Carolyn Zampano, date of birth is 8/4/1940. We're doing a procedural sedation with 8 of etalidate and 100 of fentanyl for cardioversion for a-fib with RVR. We'll be shocking synchronized at 200 joules. She has no known allergies. She has been intubated in the past without difficulty, and her vital body is 2 on exam. We have all our equipment ready.
What equipment do you have ready?
All right, so we have suction set up. She's on 2 years nasal cannula just for comfort, and she's on end-tidal, which is reading over here. We have nasal airway should we need it. We have a BPN back here should we need it. And we also have the code part right here. And she's hooked up to the AED machine. We have 2 good IVs, and she has a liter of normal saline running just for symptomatic treatment.
Okay,
She has
perfect.
She's a good resident or trainee. She really covered it very quickly. Just real quickly, just at a high level view, Dr. Moore, how do you actually approach timeout? And you use the word timeout, and we call it pre-procedural debriefing, but what do you mean by timeout, and why is it such an important part of the pre-procedural experience?
Yeah, this is one of our star residents, one of our chief residents, Tim Ryan, does a fantastic job kind of summarizing things. But basically, it's a time to make sure everybody's on the same page, because this procedure involves obviously not only the physicians, but the nurses and sometimes the techs who are there to help with the equipment. So just taking some time, making sure everyone, and we didn't put that on video, but we did have time where we involved everyone on the team. And there actually is a nursing checklist prior to procedural sedation as well. So you might think about it like the airplane pre-flight takeoff checklist, going through things. Tunraya summarized it. You know, the important things, I think suction is actually one of the most important things to make sure it actually works. Having oxygen, having appropriate monitoring, ideally 2 good IVs, make sure everybody knows what medications we're planning to give and that those are ready. Having a bag valve mask available to assist if somebody gets a little too deep on the procedure. And then, you know, ultimately actually having airway equipment, at least, you know, it doesn't have to be open and right at the bedside, but, you know, right outside the room, have a cart, you know, and you know, be prepared for that if needed. So really the timeout is the time to make sure that everything's covered, that everybody's on the same page, and that we're ready to do a procedure that, you know, usually goes very well, but can also get you into trouble if you're not prepared.
Fantastic. So should we go to the next video?
Yeah, I do see a question in there about if the patient presents with a-fib for the first time, we start them on anticoagulation. I've actually been doing that more frequently these days. If you get them rate controlled and you put them on something like Eliquis and you don't cardiovert them, which is not unreasonable, I usually would do that in consultation with a cardiologist. So I would call them and say, hey, you know, even if whether they've seen one or not, find one that they would be seeing, or talk to their primary care doctor and say, you know, what do you think? What do you want to do? Does this patient need to be admitted? Do you want to see them, or could we start them on some anticoagulation and have you see them as an outpatient? So that certainly is an option. But anyway, digress a little bit, so you can continue with the next step, Dave.
We're starting out the medication, and this is the fentanyl to start. Was that 100 milligrams or micrograms? I'm sorry.
Yeah.
Okay, very good. And the next medication. Okay. So 8 milligrams of etomidate. We're gonna flush that. What I often do is kind of have them count backwards from 30 slowly.
Carolyn, you want to go ahead and count backwards from 30?
Yes.
Didn't get too far there.
So we are synchronized. We are at 200 joules. I'm going to charge. All clear. Shock administered.
This is your end file here. Accommodate is nice because they tend to breathe through it, and they also tend to come out of it fairly quickly.
So right after, so with cardioversion, how quickly, Chris, do you often see the response? It should be immediate, correct?
Yeah, just to comment on this particular, first of all, the medications, etomidate is a short-acting barbiturate that we use for sedation. It often is used for intubation procedures, but keep in mind the dose for that is about 3 times what we use for sedation. So if you're going to intubate somebody, you give typically 0.3 mg per kilo, which would be like 20 milligrams, and that really puts them out. But then they need to be intubated. So for procedural sedation, 0.1 per kilo, we went ahead with 8 milligrams here. And then we also added some fentanyl, just because if you've seen somebody go through this, it looks like it could be quite painful. I've never actually done it myself. And I actually had a little bit of a regret when I was filming this. I think I missed the point where we actually shocked her. I don't think I had the camera on her, because you'll actually see the body jerk or shake when the shock goes through. And yes, you're correct though that if the cardioversion is successful, it'll be right away. Meaning immediately after the shock, you look at the rhythm on the monitor or get an EKG, and it should hopefully be back to where you want it. We went ahead with the highest dose of 200 joules as your maximum for biphasic cardioversion. And a-fib can be tough. You just don't want to do it again. So, and we had actually talked to the cardiologist about this, and he said, yeah, just go ahead with 200 joules to do it. So those are the things I would note. Ideally, you do synchronized cardioversion, so you're not putting a shock on top of the QRS complex, which could put you into a ventricular arrhythmia. But overall, yeah, she obviously became pretty sedated pretty quickly. I use 30 as a countdown technique. Some people just are more recalcitrant to medications, and you may need to redose things a little bit. Procedural sedation is a bit of a balancing act between appropriate sedation and going a little too deep. And that's where, each patient can be a little bit different on how they respond to medications.
What if you decided to not use etomidate? It's funny, in pediatrics, there's been some shying away from etomidate because there are some issues with, at least hypothetical issues with sepsis and diminishing cortisol response. And so I'm just curious, if you were not going to use etomidate, what other sedation medications might you consider? Would ketamine be on the list?
Sure. So first of all, etomidate, the side effects is adrenal suppression. That's typically with repeated doses or being on it more long-term. So, the data hasn't shown that for a single dose, that it's really much of a problem. But you're right, it can cause adrenal suppression. The other 2 agents I would probably consider here would be, Versed or midazolam. It's a short-acting benzodiazepine, which will put people out a little bit in combination with fentanyl. The other one would be propofol, which is very good, especially for brief procedures. It really will put people down. Ketamine, I do use that a lot more in the pediatric population. I have done it in adults. It's a dissociative agent, and they usually, will forget what's going on. But you have to do pretty high dose in the adults, and they tend to be out for a little while. So I really tend to go with the more short-acting agents rather than use ketamine in a situation like this, but it's not completely out of the question.
Fantastic. Curious if anyone has any questions about the sedation. If not, perhaps we can move on to maybe looking at the, it looks like there was a post-second shock. Do you want to take us through this a little bit?
Yeah, sure. You gonna play it? Oh, the EKG. Second shock, she dropped the saturation slightly to the high 80s. You get a little bit of diaphragm ventilation to assist. But we did get her back into sinus rhythm on a second shock.
So between the first and the second, did you give her any more medication, or she just over time became hypopneic or developed a little bit of respiratory pause.
Yeah, I mean, if I were to do this again on her and I knew what was going to happen, I would probably go a little bit lower on the dose, but you don't have a crystal ball. So in this case, she did go a little bit deep, meaning she started to drop her respiratory rate and her oxygen saturation started to drop a little. So, the first rule of life in emergency medicine is don't panic. So we were prepared for this. We had a bag valve mask and we just assisted her a little bit to get her oxygen level back up. So not a big problem. It's, of the procedural sedations I would say maybe 10% of the time that happens. So it's, I wouldn't call it exactly a complication, but it's something that, you need to be prepared for, that sometimes they go a little too deep and you want to be able to assist the, keeping the oxygen levels up.
Yeah, I just would love to play this video again. I think this was a perfect example of why you do a timeout and why you have equipment ready prior to initiating a procedure, because the bag valve mask, the BVM, was there.
Let's just get that second shot. You drop the saturation slightly to the high 80s. You get a little bit of bag valve.
Can you describe a little bit of the approach around BVM and what you're actually doing here to support her proper ventilation and oxygenation?
Yeah, so in this case, we have a very good nurse who's helping us out with this. I would say the most important part of bag valve mask ventilation is getting the seal correct on the face. And that really means a little bit of a jaw thrust. So you're keeping the jaw up, and ideally you're angling the head back a little bit to try to keep the airway open. And then at the same time, you're keeping a seal on there. So a two-handed technique is really the best way to do it. What you see sometimes is people just press the bag down on the face. And that really, the airway is still usually kind of still obstructed. So you really need to try to lift the jaw at the same time you're pressing on the seal. And then whoever's doing the bag usually can feel it if it's doing well. You can also see chest rise, but with a good seal and a good positioning of the face mask, when you squeeze that bag, you'll just kind of feel it go into the lungs in the right way. And that's what was going on. So, and I see a question, would you have RT on standby for that reason? It depends on your hospital resources. Certainly not unreasonable. RT respiratory therapists are very good at doing bag valve mask. Usually they know how to do a good seal. So it's certainly, if they're around, do you want to call them for every procedural sedation? It depends on your resources. I mean, some, hospitals, if they're not too busy, they may be willing to do that. I typically don't call RT for each procedural sedation unless I really think it's going to go to intubation or it could be really complicated. But that's certainly not unreasonable to do.
I'm curious what the attendees think about the EKG post cardioversion and what differences you see between the pre-cardioversion a-fib and the EKG after defibrillation. What do you see that's different here? Any thoughts? So someone said P waves are present. I would say I agree. I do see P waves. Dr. Moore, do you concur?
Yes, I concur. The EKG is not perfect. It's got a bit of a wandering baseline. But yes, you can certainly see P waves. I think it's probably best evident in V4 through V6 there.
Yeah. Almost looks like she may have first degree heart block. What do you think? Looks a little bit. I don't know. I'd have to calculate it out.
Yeah, I mean, sorry, had a little trouble with my voice, but the PR measured on the EKG is 185. So 200 would typically be a long PR or a first degree block. So, and that's one full box. So each of the big boxes is 0.2 seconds. So it's maybe close to the borderline, but I don't think I'd call that as a first degree block based on what I'm seeing.
Yeah, it's funny. It's slightly different than reading a lot of pediatric EKGs, which with P waves are a bit closer to the QRS. Yeah, so great. And then also, obviously, the rate looks much more regular. I think we can all agree that the spacing between the QRS waves seems much more consistent compared to what we were describing before as irregularly irregular, looking at the distances between these two, for example. So fantastic. So maybe let's go to this next video, which is the post-procedural pre-discharge.
Okay, good morning again.
Good morning to you.
How you feeling?
A little tired.
Yeah, all right, well, you went through the procedure, you did well. Heart rate's down to a 65 with a normal sinus rhythm, which is what we wanted.
Okay.
Do you remember anything?
Just sign the papers.
Okay, and that's the last thing you remember. So no pain, nothing like that. Okay, that's good to hear. So we're just gonna watch you here for probably an hour or so to make sure the heart stays in the right rhythm. And then we'll get you home and you can follow up with the cardiologist, okay?
Sounds good.
Okay.
You know, it's so it's one of the reasons why I wish I was on and off practicing adult emergency medicine. It's great to actually ask patients. You can actually talk to them. Sometimes kids you can't talk to, or you don't fully understand. But you know, I do a lot of ketamine sedations, and you know, there sometimes is some groaning. Mostly I do ketamine sedations for orthopedic procedures. Sometimes there's a bit of groaning. Sometimes there's movement. And you're always worried that the child's actually feeling pain or having discomfort, and that's the worst thing. Ketamine also has that amnestic effect. So what a wonderful experience that this patient had a sedation, and you know, without sedation and appropriate medication could have been painful or uncomfortable, and she doesn't remember anything after signing the papers. And yeah, I just think it's a wonderful case that you actually converted her. She had no memory of the procedure. And did you end up sending her home?
Yeah, we did. I didn't follow up on her long term, but in the short term, she did well, as far as I know.
Great. Curious if anyone has any questions for Dr. Moore. Once someone said heart rate's controlled. I think Danielle had a question. If a patient presents with a-fib in the ED for the first time, would we start the patient on an anticoagulant in the ER and have them followed with cardiologist, or we would let the cardiologist start on the anticoagulant? I think we sort of covered that. Would you agree?
Yeah, no, I mean, if I didn't clarify that appropriately, I mean, again, I would do that typically in consultation with a cardiologist, but it's certainly not unreasonable to, in this day and age, when we have fast acting, you know, new onset oral anticoagulants. I mean, that's usually what they're going to do for them in the hospital is rate control them, put them on an anticoagulant. You know, might get an echo to see if there is a clot, but you know, unless you're going to try to get them out of a-fib, which we did in this case. But you know, to be honest, there's literature suggesting that long term it may not be super helpful to get all these people out of a-fib. It's, you know, something that's still done. And again, this was done in consultation with a cardiologist who felt, you know, maybe we could keep her out of a-fib, but some of the literature doesn't, you know, suggest that it's super helpful. So certainly rate controlling and anticoagulating is a very reasonable approach to patients, even with first-time a-fib. And you generally don't want to cardiovert somebody who you don't know when the a-fib started. You could cardiovert somebody either chemically or electrically if, you know, it was the first time a-fib and it just started like a couple hours ago. But if it's been there for more than a day or you're not sure, which is often the case, you really want to be careful about cardioverting them before they're anticoagulated. So, you know, rate control and anticoagulation is a good way to go.
Does anyone have any other questions before we wrap this up? This has been an amazing discussion. I think from my standpoint, I'm again not an expert in adult emergency medicine, but this case takes you through the gamut of making a diagnosis, taking you through a procedure, looking at physical exam findings, looking at the EKG findings, and a great outcome. And a happy patient at the end of it, and providing high quality care. and the concepts of shared decision making. Those are sort of the key takeaway points that I took out, and also the concept of timeout prior to a procedure and having all your equipment available, which was key in this case as well. Any other
Yeah,
questions?
when you approach these cases, when you go in to start the cases and film them, you don't know how they're going to turn out. So it's this one I think did turn out well. It was, you know, a minor blip with the assisting with the bag valve mass, but that's part of the practice of medicine. So yeah, I thought it came out as well as I would have hoped. But you don't know that when you're going into video these prospectively. So
yeah. Well, that's the beauty of emergency medicine in general. You don't exactly know what the shifts are going to be like until you show up and experience it. So that's why we love what we do clinically still. So I say this in front of everyone, and just to you, Chris, it's an honor to work with you. It's an honor to see you teach and experience you here live, but watching you take students through a case just makes me even more honored and feel fortunate that we're together in this journey to bring real patient video cases to the world. I hope everyone enjoyed themselves today. I hope it was a great experience for you all. Thank you for joining. Happy to just send me an email if you have any follow-ups, david@realdx.com. Be happy to share those comments. This video will be recorded on and posted on our ReelDx.com website. And I hope you all have a great rest of the day. Thank you for joining us. Thank you,
thanks,
Chris.
David. Okay, appreciate it.